we were asked to talk a bit about the bone infection unit where we work, which is based at the Nuffield Orthopaedic Centre. It's a bit of an oddity because it is the only bone infection centre in the country that has a dedicated inpatient ward, and therefore we get referrals from a large area. And this is really a talk a little bit about the problem of bone infection and what the bone infection unit is, but also a little bit about our MDT and perhaps how that helps in improving patient experience and outcomes. And we're going to talk a bit about the evolution in thinking and how we manage infection, particularly with treatment, trying to make treatments a bit more patient-friendly. So why is bone infection so hard to manage? Well, we have a problem where we have organisms interacting with dead bone or implants, and we're all fairly familiar with the concept of biofilm, of organisms adhering to surfaces, which is where they live in Maine. But actually, over time, we've realized that the situations are much more complicated than simply organisms sticking to surfaces. And there's a good review by Masters which looked at this problem. And there are various mechanisms by which organisms can evade the host immunity. And they can form biofilm, of course they can, but they can also form aggregates where you get clumps of the organisms living together surrounded by almost like a pseudo capsule of the body's own immune cells that allow them to hide. And you get many organisms that are able to actually deform and invade and grow into very small spaces like the canaliculi in the bone, which means that the white cells can't get to them because they're hiding away in these very small areas of bone. And you've even got problems where white cells can actually be invaded by organisms and live intracellularly, completely invisible to the immune system. And even worse than that, those white cells can actually then act as a Trojan horse to carry the organisms to areas of inflammation, which can then actually cause infection in newly implanted new implants. And so that's one of the problems. But there's this concept evolving as well that actually there's this issue of the microenvironment, and it's about the microenvironment, the kind of the combat zone between the host and the organism that's really important. And it's one of the things that we can try and influence to improve outcomes. And you can see here, there's some evidence suggesting that these staph aureus can be very sneaky. It can actually sense when it's close to a hole in the bone, and then it can actually deform and it can change shape and it can elongate and actually invade that space. And then it can grow and divide along that space to get into areas that the immune cells just can't get into. And of course, the situation is made even more complex when you have a healing fracture, because the normal process of healing can be interrupted by the body's inflammatory response in relation to infection, which can then stop the fracture healing process, which makes things very difficult. And if you have infection around implants, then you can get this vicious cycle where the inflammation caused by the presence of infection causes osteolysis, which then causes instability. And one of the crucial things in infection is instability is brilliant for the organisms. It helps them get the upper hand in the microenvironment because it interrupts all the important neovascularization and processes that actually allows your host cells to come in and deliver immune cells. And conceptually, we're now thinking almost like a zonal model, that there are different zones of that are important in infection. There is obviously, thinking about the organism itself and its virulence, but then there's the issue about how the organism interacts and speaks to its neighbors in the biofilm, and then the interface between the biofilm and the organisms and the hosts. And then, of course, the regional situation. So what's the local blood supply like, and all those sort of things. And of course, the host themselves, the ability for the host to mount an immune response. And thinking about all those factors is really important in managing infection. And the problem is that when you have an infection, it causes low-grade inflammation, which causes lots of other problems in all the surrounding tissues. So you get issues with scarring, you get disuse of the muscles and the tendons, you get poor perfusion, edema, and that all leads to really bad problems that are difficult to manage. So the bone infection unit, we're an MDT, and we cover all elements of bone infection, from bone infection involving the long bones, fracture-related infection, non-unions, but we also have a big practice in prosthetic joint infection, foot and ankle disease. And we have this inpatient ward. It's a 26-bed ward that's dedicated to managing these cases. It's unique in that you cannot get into this place unless you're under at least shared care. So you have to be under the joint care of an orthopaedic surgeon in the specialty of that interest, along with at least an infectious disease physician at the same time, and maybe even other services such as plastics. You can't get in as a single care, which I think really helps in improving outcomes. There are lots of people involved in the MDT, and I'll talk a little bit about it. Why do we need an MDT? Well, we've got a difficult nut to crack. We've just seen how challenging the problem is. And, I think that for me, having an MDT makes work bearable. I think more importantly, it does allow you to blame other people when it goes wrong. So that's another strength of the MDT. So how does it work? Well, all the patients we see are seen in an MDT clinic. That means they're seen in a combined clinic with all the parties involved to see the patient together. And that's time efficient because it means we can address a lot of issues in one go. And that's also associated with radiology MDT, where we can bring in MSK radiologists as well. And the key thing, I think, is it's patient-centered. So the patient's at the center, and we organize our service around the patient. And this happens right at the beginning. It means we can share our thinking, we can bounce ideas off each other, and we can come up with a plan that helps the patient. And the problem in infection is we're often dealing with sensory overload. We have these problems that are quite difficult to manage, and you're faced with this issue. And the first initial reaction is you see this and think, oh my goodness. And what the MDT does very well is it allows each individual with their own expertise to draw out all of the important elements that they can manage just to make that whole situation much more clear, which means that you've got a much better way of tackling the problem. And that is a really dynamic thing that actually you need to have that discussion and interplay to work out what you can do, which is why it's so important to see the patient in the same room with the same people together. One of the problems is that you have a really difficult balance because on one hand, if you're really aggressive with your excisions and you remove all the implants and all the bone that's infected, then you'll get rid of the infection. But what you then do is you just give the patient a different problem, which is a huge hole that you have to reconstruct, which is really difficult. And so we're always trying to get the balance right between taking away enough of the infection or the dead bone, but actually allowing the bone to heal and trying to sort of reduce the morbidity of surgery. And one of the problems we often see is that people are very radical in their resection. They're too aggressive. And, whilst that might be good for the infection clearance, it's bad for the patient. And sometimes we can get away with removing a cavity. So we leave behind intact bone. Sometimes we have to remove a segment of bone and think about the reconstruction thereafter. And this conversation between all the parties really helps in the decision making. The other element in this is the radiology MDT. So after we can discuss all the cases with the radiologist, which really helps us work out what we have to do. And a lot of this is understanding where the disease is so we can actually get to the disease and treat it. And so I think radiology is often a forgotten part of that really important MDT that is crucial for our success. And again, if you know what you're dealing with, if you know your enemy, then you're far better placed to actually be able to deal with the problem. And I think the crucial thing is that a lot of these cases, there's no role for exploratory surgery in these cases. We have to understand them before we intervene. So how can the MDT help in managing infection complications? Well, first of all, having a structured MDT can help avoid having complications in the first place because any early concern you can deal with, and you can develop standard ways of treating people where perhaps you identify those at high risk and you can treat them differently, such as open fractures in ways that avoid infection in the first place. One of the really important things I think is difficult, isn't often appreciated, is that the MDT really helps avoid lost time. And one of the real sad things we see is that if you don't plan what you're trying to do and you rush in to do stuff, then what tends to happen is you just build up problems for the future. And MDT is very resource intense. It's quite a lot of energy you have to put in to make it work, which is painful at the start. But if you do that, the patient's journey is often significantly better. The problem with infection surgery is often a lot of time has passed. A patient develops a complication. And when a patient develops a complication, unfortunately, there are different reactions as a surgeon to those complications. But sometimes that reaction is to delay, wait, deny, and those patients effectively lose time. And unfortunately, every patient has a pot of goodwill that they can put up with treatment. But if time goes on, you're gradually paying out that pot of goodwill. And the tragedy is that if you see people several years down the line with infection who arrive and have got an entirely salvageable problem, just needs quite a lot of energy to sort out. They may not have the goodwill left in the pot to deal with that. And there are many people who decide they want an amputation purely because it's got to a point in their life where their marriage is on the rocks, their mortgage needs paying, they need to have closure, and they cannot then invest the time in the resalvage. If we knew about them earlier, we could have sorted them out. So we really need to look at trying to avoid losing time to make those decisions. The other thing is it can help us choose the right intervention at the right time. There are lots of different examples of how infection can present, and in each of these cases, there is a different strategy. If you have an early fracture-related infection, you may have concerns about the wound redness, but if you intervene early, then there's a chance you're going to open the wound, be able to close it, and then give that patient a more significant morbidity of perhaps a free flap surgery when, if you were a patient, it might have resolved. The case in the middle essentially is a fairly straightforward situation. You can open that and close it fairly straightforwardly. So the cost of intervention is low. So intervening early to deal with that problem is probably better. The case on the right is established infection. And whether you operate on that in 2 weeks or in 6 months, it's the same operation. So therefore, you can afford to plan, optimize the patient and improve the outcome by getting the patient ready and improving the microenvironment in favor of the host. And so it's all about trying to intervene at the right time and do the operation that's going to get the patient better with the least morbidity. The other thing is the MDT, it helps build resilience. And these cases are really difficult because they're hard. Often the hosts themselves have challenging problems. They may have substance abuse problems. They may have depression. They may have other issues that mean that they're difficult to manage. And the problem is that if you deal with these people in isolation, you can get into a sort of difficult spiral where you have negative experiences. Maybe you take on cases like this and your colleagues say, don't do that, you shouldn't do this. And then you have a bad experience and it erodes your confidence. And that can often lead to people effectively losing heart and stopping to treat. So the MDT builds resilience in the team to be able to do these difficult cases and take on these difficult cases of failure. And we want to avoid this issue of as you lose confidence, you then are less brave. And if you're less brave, then effectively there are patients that you could treat, but you feel you shouldn't because you've lost confidence. And again, one of my colleagues once said to me, don't let your successes go to your head, don't let your failures go to your heart. And the team helps avoid that pendulum one way or the other. The other thing is it really helps standardize care. So one of the great things about working with a team is that you can do things the same way on a regular basis, which means that things can get done in a certain way that means that the outcomes can be improved. There isn't that kind of variability of practice. And often getting good outcomes is not sexy. It's just doing the boring things really well. So actually just getting all of the small things right to move things on to improve outcomes. The other thing that I think is really valuable about MDT is the messaging. So often patients have seen a lot of people, they've had lots of promises made to them or lots of plans made that haven't necessarily come to fruition. And the real strength of MDT is that it gives a very clear single message to patients, which really helps because often there are trust issues about whether you're just the next group of people that are going to inflict harm on this individual. So it allows you to make patient-centered decisions with the patient. They can ask their questions and it gives a very clear and immediate response. And often there's a theme that the patients often talk about is that before I was given potential options of treatment. They'd go and see a surgeon, then they might go and see a plastic surgeon, they might see an infectious disease physician. And, they were told we could do this, these are all options. But when you meet the patient in a group, you then change that to actually they have a plan. So they can actually go away with a way forward. And for a lot of patients, psychologically, that's really important because they just feel a bit stuck, and being able to move forward and make plans for the future is really important. So how do you gain that trust? Well, it's really important to try and empower these patients. They often feel completely powerless because so many bad things have happened to them that just feel completely passive and not really involved. So that really helps to try and help those patients make their own decisions and feel empowered. Information is really crucial. So giving them clear expectations of what's going to happen next. The unified messaging is really helpful because it just gives more confidence to patients. It's important that we try and be honest about what we can achieve, and patients can often arrive with either really overinflated expectations of what we can achieve or absolute unfounded pessimism. So that's important. And then often it's just about trying to make it really easy for patients to identify when there's a problem. It's really interesting. A lot of patients, when they do have a problem, just cannot get fed back into the system. So having mechanisms in place to allow patients to say there's a problem very easily is really important. And then listening to their concerns. Sometimes the things that are on the patient's mind, you haven't crossed your radar until you listen and actually realise. And a lot of people can feel so much better with being a bit of reassurance. And then we can preempt potential triggers for problems. And again, it's all about trying to get the balance between delivery and our promise. We don't want to get that wrong, because we don't want there's a lot of time invested for these patients. We want to make sure that they are on board and that we can actually do what we say we can. So how has the MDT changed our practice over time? Well, there are a few things that it's caused an evolution in. So traditionally, infection surgery has very much been a two-stage affair. We've all had the dogma: you never close a dirty wound. We lay things open to manage infection. We take out infected metalwork because that's where the infection is. And so we've often tried to think about this concept of, let's get everything infection-free and then come back later and sort things out later. And we were much more aggressive in the past with segmental resections. We use a lot more external fixation, which is tough for patients. And we tried, often it was hard to convince plastic surgeons to cover wounds early, particularly infected wounds, because they're all worried that their coverage would result in failure. And we were giving lots of antibiotics with long hospital stays. And over time, that's now changing. So we're moving much more to single-stage surgery. We're trying to be less radical in our resection, because, again, our surgery is not about removing all infected tissue. It's about removing the areas where there's dead bone. You're not doing a pneumonectomy for a chest infection. You give antibiotics, it's vascularized, it'll get better. And we're trying to apply that same principle to surgery, judicious surgery. And we're trying to move much more to internal fixation with local antibiotics and combined orthoplastic procedures, so single-stage procedures. And the BRU is slightly unusual in that it takes on all cases and it tries to do all cases in a single stage, which, from the point of view of patient outcomes, is a lot better. And we talked about that already. So one of the things is, surgery in some ways is quite straightforward. You can either choose to operate or not. But actually what people forget is there are so many things we can do that aren't surgical just to fine tune and optimize. And I see, this is my worldview of our physician colleagues and what they get up to in managing patients. So there are so many things that people forget about that are crucial in improving outcomes. And actually, most of the time in infection surgery, you're not in an emergent situation. You've got time to invest to improve outcomes. If a patient's septic, that's different. You treat the sepsis, you decompress the pus, but you don't have to do the definitive surgery at that time. The secret to success is doing things, the common things uncommonly well. So there are some principles that we take home when we deal with surgery. These are crucial principles that we apply to all our cases. We have to get samples so we know what we're dealing with, and we do that in a really strict way so that we get the most accuracy in our sampling. We have to take out the dead stuff that is infected. We have to manage any osseous dead space. If you make a hole in bone that will fill up with fluid, that will become a brilliant culture medium for organisms. So we have to deal with that. And that's we'll talk a bit about the antibiotic delivery that we use. We need to stabilize the bone, which is crucial. We need to get the wound covered. And getting early coverage is crucial, because if you sample, you know what the organism is in the wound. You close the wound, you then got a sealed system, so you can then target your therapy to that sealed system. The problem comes when you give broad spectrum antibiotics in an open wound. By next Thursday, it will be an entirely different collection of organisms, and you don't know what you're dealing with. So here's a case. This is a guy, he's had an injury. He's had a long-standing infection after a fracture. He's got a slightly wonky leg, but you can see he's got this abnormal area in the proximal tibia, and his soft tissues look like this. So, again, a lot of people would say, well, there is no treatment for this. This is an amputation. But, again, this is just doing the principles we mentioned before. So how do we tackle this? Well, we want to understand the extent of infection, so we get some imaging to see what the bone looks like. In years gone by, this would be an amputation or a segmental resection, but actually we don't have to be so radical. So this is poor vascularized tissue that needs to go, so that's cut out. We take samples to know what the organism is. We have the cavity, and then we need to start doing our excision, and we keep going until we're happy that we've cleared all the infection. We give it a washout. We can see the bone is now healthy and bleeding, and then we have to manage that defect. So we put in some local antibiotics that will, in this case, contain gentamicin. So we give very high local elution of antibiotics. We're a bit worried about the fracture risk, so we put a very simple frame on the leg to stabilize the leg. And of course, the hole needs to be managed with a flap. So he has a flap at the same time, one operation. He's up and walking with his frame. And then, the bone goes on to heal very quickly. And so within 3 months, he's out of the frame and the leg's healed. So that's a relatively straightforward standard case that we might manage in the unit. Here's a more difficult one. So an infected non-union, the bone's not looking very happy. There was dead bone at the fracture site. But again, it's the same principles we mentioned before. So in this case, after our sampling, we've assessed the bone. This guy had dead bone across both sides of the fracture. That's not going to be possible to salvage. So we excise the bone, we leave him with a hole in the bone, and then we can use an external fixator to compress the bone together so it's touching, shorten the leg, and then we can put a flap on that area. And then what we do is we make a small cut at the top of the leg, and we gradually then distract out the top of the tibia to regrow the absent bone that was missing. So this allows you to open up and grow the bone 1 millimeter a day until he's out to length. And then once that's done, then the bone is healed and he's infection free. So there are lots of techniques we can use to really help patients out. We have lots of cases with acute infection after fracture. So this is a guy that went to Turkey and got an infection, and you can see there's the plate that's put in Turkey. There's an area of dead bone that you can see in the middle on the right hand X-ray. The wound's not improving, so we've tried to optimize the host, and then we can proceed to surgery. There's a little sequestered bit of bone that's dead that's probably driving the infection. So what's the surgery? We go in, we take our samples, and in this case, we can stabilize the fracture and we can perform a DARE procedure where we retain the metalwork, but we just use local antibiotics. We've made the fracture a bit more stable. You can see the white carrier that's protecting the plate, but of course, he's got quite a big hole in his leg. So then we ask our plastic surgeon, in this case, he's having a medial gastrocnemius flap, which is a local flap. And you can see you can take that muscle, you can bring it over the surface of the plate, and then you can stitch it in place, and that covers the plate, but it also provides very well vascularized tissue to the area to improve the host status. And there we've got a skin graft on the top. It always looks absolutely horrendous at the start, doesn't it? You always get a plastic surgeon saying it looks beautiful, and you say, no, it doesn't. But, they heal well, so they do well. And this guy's delighted because he's been able to get back to work very quickly, and he's recovered from his infection. So finally, a few little things about the MDT. It really helps in building up trust. And I've just noticed that the ability to work across different teams just really helps in pushing the envelope. That it actually allows us to be a bit more brave. And over the last few years, we've really started to push what we can do. But that can't be done unless you have a team of people to share these ideas with. And I think that one of the key things is that I agree with this sentiment that many ideas grow better when transplanted into another mind. And actually, the sharing of ideas across different people, across the visitors that come to our unit, has really helped us reflect and think about why do we do the things we do and how can we improve things. And so I think in a minute, we're going to have my colleagues talk a bit about some of the evolutions in our practice. Thanks.
Thank you. He's brilliant, isn't he? Sometimes he has some lapses in concentration. This is limb reconstruction, the way Jamie does it, very occasionally. The big question is why bother with ID? Surely a surgeon can do all of those things on the left of this picture. In addition, I'm sure they could also just do those 4 simple things, choosing the right drug at the right dose, given by the right route, and for the right duration. You just look at the BNF or the susceptibility charts, job done. So I've got to persuade you that we do add value. And it isn't just ID and surgery. Of course, it's lots of other people, including the specialist nurses, the ward nurses, the OPAT team. So it's a very big team. So this MDT isn't just about medics and physicians. But let me just show you 2 studies where they have looked at what happens when you do offer the inclusion of a ID physician. It doesn't matter which of these 2 bars you look at. This is type 3. This is normal cavitary osteomyelitis. These data, I think, are from Pittsburgh or somewhere. The outcome is in grey if the surgeon was allowed to make all the choices. He had the option of phoning up the microbiology lab and getting advice, but it wasn't given routinely uninvited. So we come in completely uninvited, and we give advice, and the outcome goes up quite considerably to somewhere around 90% in this case of osteomyelitis. Similarly with slightly more complicated disease. So we think that that's a good example of how ID can benefit. Here's another one. This is from South America, where they looked at a number of variables, including let me just move something out of the way here. They looked at a number of variables, including age of the patient, the cause of the osteomyelitis being a fracture or not, the duration of treatment. None of those seem to impact on outcome. The only thing that impacts on outcome was whether the treating specialty was the orthopaedic alone or not. And that's the only significant outcome there was. So we were very pleased with this and thought we could justify ourselves. In truth, of course, it is all part of the team. And the next thing is this was a deep dive into national data. I wasn't involved with it, but we looked at the unit looked at 25,000 cases of osteomyelitis over a fixed period of, I think, 4 or 5 years. And the outcomes were divided by people who were treated in the specialist bone infection unit, the NOC where we work, and the rest of England. Within the rest of England, they were divided into the biggest practice or the 10 top biggest practices versus everywhere else. And it was an amazing outcome, really, because what we didn't expect was that the limb salvage rate in Oxford at the BIU was around 94%, and that went down to 87 and 84% respectively in the other two groups. So what we're doing, and I'm not saying it's because of ID's involvement, but there's something special about what we're doing because it does save legs. In addition, it saves lives, and we really didn't expect this. Our mortality at around 2 years is about 5% compared to 20% in the top 10 hospitals by practice elsewhere. So we're doing something right, and this is really reassuring, and we've used these data to defend the cost. The BIU actually is a loss-making department, but we get central funding because of the service that's offered. So that's why we keep going. The trust would close us down if it weren't for that extra funding. Jamie's been practicing for a very long time, and the main thing that we help with is the diagnostics, but Jamie's surgery remains important. The most important thing is the eyeball-ogram. That's both what the patient presents with and what the surgeon finds at the time of operation. The rest of all the investigations is minuscule compared to the presentation of the patient. And we help in that. Of course, we're not there at theatres, but the description that the surgeon's given their op note helps us interpret the need for antibiotics. Radiology, of course, is key. We don't do very much nuclear medicine, so bone scintigraphy and stuff is probably useless. I can't remember when we last did it. We are increasingly using PET scans, but the biggest modality is plain film, plain X-rays. Histology is very sensitive, but not particularly full of information. It just tells you if there's an infection or not. And the microbiology is what we rely on most of all for defining the choice of antibiotic. Bloods, including CRP, we can ignore almost completely in the context of bone and joint surgery. The diagnosis in the lab is made by 5 individual samples, each taken with clean instruments and each separately labelled. This is done with religious fervour in surgery, and they get to our lab and they're processed in a very specific way, and we have a good pickup rate and we have a very clear diagnostic. This is based on work done by Bridget Atkins and co. Back in 1998, and this has now become a sort of international standard. If there are 5 samples taken and 2 or more tend to be 2 or more have an indistinguishable bug, that's diagnostic of infection with that bug. Histology is useful and very important. Only about 40% of patients in the UK actually have histology done, so we try to encourage it. The other thing is, for those who don't know, the pig is the most common mammal associated with MRSA. This is Jamie when he was learning about infection prevention and control. So we've got to work out, including with these resistant bugs, how to choose the right antibiotic. And we have this motto that we start smart and then focus. We start smart using very broad spectrum antibiotics, and it's based on some work done by one of our registrars. This is 15 years ago. It's been repeated by Maria much more recently. But if you look down the left-hand side, these are the various antibiotics that can be used empirically whilst we're waiting for the cultures to be available. And across here is the type of surgery. Just look at all patients. This is the easiest one. And you can see that there's actually a huge advantage of using broad spectrum, including a glycopeptide such as vancomycin and an anti-pseudomonal penicillin such as meropenem. So all of our patients get vanc and mero, which is okay. It's not very good antimicrobial stewardship, but as long as we do focus down onto something much more specific when we have time, I think we're justified in doing that. So when we focus, we look primarily at the susceptibility of the bug, but we then take into account pharmacokinetics and pharmacodynamics. We've got to think about the patient, what are the drugs they're on, interactions, and their comorbidities. And of course, we need to look at the institutional implications from a stewardship point of view and cost. So we work on all of those. When we look at oral drugs, there's a relatively limited list of drugs with favorable PK data, and these are those with very good oral bioavailability. We also choose drugs that are active against biofilm, which is this slime layer that they get, particularly on metalwork, but also on bits of dead bone. And you can get biofilm in sort of floating lumps as well. So we're still learning quite a lot about it. This is Jamie when he was morphing into an adult. So the next question we're going to do is about the route of administration. And if you read the books, these are all the textbooks that were available to us when we were in training. And all of them say that the treatment of osteomyelitis needs the combination of careful surgery and prolonged parenteral high-dose antibiotics. So we challenged the idea of these. We're gradually challenging them. The first thing we looked at was parenteral antibiotics. So this is a group of conditions, all of whom have in common the fact that they have been subject to prospective randomized trials comparing IV and oral therapy. There was none of them in which IV therapy proved superior. And that's important from a general principle. I think we're so reliant on IV. The dogma is that it is better for no good reason other than it feels stronger, it feels better, and it's probably more expensive, therefore it must win. But all of these have been subject to prospective trials. There are, of course, some things that haven't been tested in this case, and that would include meningitis, septic shock, and a couple of other things. But almost everything will respond to oral antibiotics if it's chosen carefully. We said we were going to test that out in musculoskeletal infection because classically, long-term IV therapy was meningitis, osteomyelitis, and endocarditis. So we looked at musculoskeletal infection. We did a trial called the OVIVA trial, oral versus IV antibiotics in bone and joint infection. And we invited any person that would ordinarily get 6 weeks of antibiotics, and we randomized them to change to orals within 7 days or to continue as planned prior to the trial. We followed them up to a year and looked at failure rates. This is you can look at any of these populations. The best one to look at in non-inferiority trials is the per protocol population. And provided that the upper limit of the confidence interval didn't reach 7.5, which is what we chose as our non-inferiority margin, we proved non-inferiority. It's probably easier to appreciate just with a Kaplan-Meier file, most boring graph in the world, but this is exactly what you want in a non-inferiority trial. We're not looking for, we don't expect orals to be better than IVs. What we really want is to prove that they are non-inferior, and this boring graph demonstrates that. So we think with that trial, we've been an advantage to our practice because we don't have to use IV lines at all. Fantastic for antimicrobial stewardship because we can focus down much, much more closely. It saves quite a lot of money. Most important, it's really good for patients because it provides them the autonomy in the treatment and the independence from the OPAT team. The crowd here is my wife and I and some of our statisticians and research nurses and kids are spelling the word OVIVA. So the next question we ask is, what's the right treatment duration? There's a massive variation here, even within me, and I don't know why. It's unfounded, but certainly between us and between sites, huge variation, and there's a very large number of variables. I'm going to show you just, I think, one slide about it in bone and joint infection. But this, like my previous slide, shows, I think, 45 trials that have looked at duration of antibiotic therapy in various conditions. In none of them, these are all prospective, randomized or quasi-randomized trial, and in none of these trials was the longer course of therapy found to be superior than the shorter course. Some were comparing 5 days versus 8 days, some were comparing 2 weeks versus 4 weeks, but in none of them was the longer course superior. So we've already said that we should use more orals and we should use shorter courses generally. We don't know when that's going to stop. The way we did it in 2009, when I was first appointed here, there's a guy called Philip Bejon upstairs working with Ivor Byron and others, and we routinely had people on antibiotics for a year, sometimes 2 years, especially if it was a dare. So if you look at this top solid line here, this is people on antibiotics, and they had roughly a 5% failure rate whilst they were on antibiotics at 6 months. We then restart the clock when they stop antibiotics, and there are 3 lines here. One of them is stopping antibiotics after 6 months therapy, one of them stopping antibiotics with between 6 months and 1 year, and one of them is stopping therapy more than 1 year, and you restart the clock, and you'll see that none of them have an advantage over the other if you look at it from the time of stopping therapy. The implication of this is that carrying on antibiotics for a long time doesn't reduce the risk per se of treatment failure, it merely delays it. That's quite a nuanced argument that you have with patients who often want to carry on for ages, but long-term therapy is not necessarily the answer. My rule of thumb, and as I say, there's a lot of variation in this, is that we would generally, with bone infection without metal, treat for 6 weeks, with metal 12 weeks, unless it's a knee when we go on a bit longer, and with fracture-related infection until union. Suppressive therapy is quite often used, particularly in people coming to, in their later years where they don't want an operation. We can just damp things down as best we can. It reduces pain, reduces discharge. So we frequently use it, but it isn't our preferred thing, and it doesn't create a cure. In the end, of course, the right management has the patient right at the very, very center of it, and there's a huge number of factors that we have to take into account. But eventually, as Jamie's previously said, good outcome depends on the right teamwork. Thank you.
Brilliant. Well, thank you to Matt and Jamie for this. In terms of the duration of antibiotics, I'm going to talk about a trial that we've just finished and are in the process of publishing about how long we actually should treat with antibiotics for. And of course, the rationale for that is multiple, but one of the things being the increase in antimicrobial resistance, to which we're all contributing by giving a standard 6-week or longer course of antibiotics for people that we treat on the bone infection unit. So, of course, we like to follow international recommendations when we treat, and for both prosthetic joint infection, but also for fracture-related infection and osteomyelitis, the recommendation has always been to give at least 4 weeks of systemic antimicrobial therapy. We now know that could be oral or intravenous based on the Oviva study, but still, nobody's brave enough to suggest a shorter duration than 4 to 6 weeks. The problem being that if we give people 4 to 6 weeks of antibiotics as a minimum, even with good oral therapy, between 5 and 10% of people develop quite severe side effects from that treatment. And in terms of the side effects, we tend to minimize them, I think, for people receiving systemic antibiotics. So in starting this study, I went and talked to some people in the waiting room of the bone infection clinic and asked them a little bit about, what are the worst side effects that they get with antibiotics, and trying to understand, would reducing the amount of antibiotic treatment and reducing antibiotic side effects be something that people would contemplate, even if it would give them a smaller chance of cure for their orthopaedic infection. And something that I found in just that waiting room chat surprised me a bit, but then shouldn't really have surprised me, because patients weren't really that worried about problems with their blood tests, problems with their kidneys or liver. What they really cared about was diarrhea. And if you think about it, antibiotic-induced diarrhea is a really big deal if you've just had an operation on your leg and you can't walk. So This is one of the things which is a very, very common side effect of both oral and intravenous antibiotics, and something that I think we should have paid a bit more attention to. And the majority of the people that I spoke to were happy to drop their cure rate from 90% to 80% in order to get rid of 4 weeks of diarrhea. In terms of the route of antibiotic administration, Jamie's already described some cases where antibiotics were implanted directly into the bone where they need to be. And for other infection problems in bones and joints, including prosthetic joint infection, there are, of course, other options and other carriers that can be used. So people are probably familiar with spacers for two-stage revision of prosthetic joint infection. Those are made out of polymethyl methacrylate that's mixed with antibiotics. There are lots of polymethyl methacrylate products that come already with antibiotics inside that can be used both for spacers but also for fixation of new implants. But in terms of the absorbable carriers, there are different options that absorb at different rates and that elute their antibiotics, usually over a period of about 3 weeks. So in terms of this trial, the Solario trial, the question that we asked was, can we drop the duration of systemic antibiotic treatment for people who've had antibiotics implanted directly in a carrier where they need to be into a bone or a joint space? And this is a open access publication that describes in a lot of detail what the protocol for that study was. And like I said, our non-inferiority margin of 10% was something that patients told us rather than being arbitrarily taken out of thin air. And this is the flow through the study. So we screened just over 1,200 people. About as many didn't consent to participating to having shorter antibiotics potentially as were randomized. Interestingly, only 43 people were excluded for having germs identified at the time of their operation that weren't susceptible to the implanted antibiotics, which is one of the exclusion criteria. And then 500 people went through the study, of whom 497 allowed us to use their data. And we had to look at different populations here. So we followed up people quite proactively. We contacted their GP and we had a look at their NHS spine record, which allowed us to have a very, very low loss to follow-up rate. And in terms of where people were recruited, we had, I think, 25 or 26 active centres, including 4 in mainland Europe and lots in the UK. The majority of people who are affected by orthopaedic infections are males, so that's not an unexpected sex ratio. And we represented both bone infections and joint infections. Some people had a combination of both or had very complex bone and joint problems, including associated with sacral pressure sores or associated with megaprostheses. So these were not necessarily simple infections. And of course, different recruiting centres contributed a different mix of patients. Some people were predominantly sort of diabetic foot-related infection, and in some cases it was more prosthetic joint infection. And, you know, a reasonable minority of people had new metalwork implanted at the time of their operation. Nobody was allowed to have retained infected metalwork and participate in this study. And most people had already had a previous operation on their affected limb. So in terms of what local antibiotics were used, the majority of people who participated in this trial had absorbable antibiotics, often in more than one carrier, and some people only had a polymethyl methacrylate fixation cement or a spacer. And what I wanted to point out is that gentamicin and vancomycin were probably the 2 most commonly used antibiotics, but you're using essentially a single daily dose of antibiotic, but because it's at the site that it needs to be, it's not circulating all around the body, and you're doing quite a lot for antimicrobial stewardship if you can get away with just that single daily dose of gentamicin. And this is the measured, the raw data for our systemic antibiotics that were used in the study. So these were quite well recorded, and you can see there's a massive difference between the short group and the long group. Median duration of treatment, which is a jargon term for how you count antibiotics, was 6 days in the short group and 42 days in the long group. And people had antibiotics at other times as well. We couldn't stop that from happening, but we measured it and we found that the pattern of antibiotic use subsequently in the 12 months after people randomized was about the same in both groups. We saved a suitcase load of antibiotics in total across the 500 people. So, comparing the two, roughly 250 people in the short versus the long group, that's 15 kilos less antibiotic that you're putting out there into the environment. Like I said, compared with a roughly single daily dose of implanted antibiotic. And importantly, we met our non-inferiority threshold, looking at both definite treatment failure, which was evaluated by an independent and blinded endpoint committee, but also for other sort of definitions of treatment failure. So in terms of definite treatment failure, 14% of people who were treated with at least 4 weeks of antibiotics failed treatment by 12 months, compared to 11% of people in the short group who had up to 7 days. And our major sort of improvement in terms of patient care and experience was reducing the duration and severity and frequency of symptoms associated with treatment. So all patients were asked at 6 weeks, at baseline 6 weeks, and then 3 to 6 months, do you have any symptoms associated with your treatment? Because we didn't want to call them side effects, because we wanted to ask everybody, including people who weren't taking antibiotics. And we found that, as expected, diarrhea, nausea, other side effects, vomiting, and even fatigue was reduced in the group of people who were not taking antibiotics for 4 to 6 weeks. 2 people in the long group got C. diff, 0 people in the short group got C. diff, which is good. And we did drop hospital stay by a mean of 3 days in the short group compared to the long group. And that's probably contributed primarily by people having antibiotic decisions that maybe held up discharge, but also having to have intravenous antibiotics in hospital if, for example, that was chosen in their centre. No difference in the overall survival between our 2 groups of treated patients. So if we implant antibiotics, we can often get away with avoiding systemic antibiotic therapy for 4 to 6 weeks or longer, assuming that the implant has been removed and assuming that the bugs that were identified at the time of surgery are suitably treated by the implanted antibiotic. You would still need to use systemic antibiotics if somebody's got a Staphylococcus aureus bacteremia or infection at another site, or if they've got retained implant. And we can all do our bit for reducing antimicrobial resistance. This is obviously the work of many, many people, and I'm very grateful to Matt and Martin McNally, who started this trial, for letting me participate and get involved, and also to our patient representatives who helped formulate the plan. And thank you all for listening.